dear participant. As you may know, I'm the Educational and Patient Program Manager for the European Reference Network on Rare Hematological Disease, EuroBloodNet. I'm Mariangela Pellegrini, and it's my great pleasure to welcome you on this third session of the topic on focus on cutaneous lymphoma for patients organizations, on behalf of a great team that has established the program that I'm happy to thank with all of you. So first of all, I want to thank the Lymphoma Coalition. The representative of the Lymphoma Coalition, Natasha Bolagno, was supposed to be there. She apologized with everyone, but she could finally not join the webinar. Then I want to thank the Cutaneous Lymphoma Foundation, represented today by Susan Thornton, who is also one of today's speakers. And finally, France Lymphome Espoir and Eurordis that has collaborated for the establishment of this program. As you may know, the objective of this program is really to disseminate among patients' organizations very innovative topics related to cutaneous lymphoma, and to give visibility to the medical services available in Europe, the last quality of life cutting-edge advance in the field of this very rare condition, and also visibility to its treatment options. As you know, this program consists of a cycle of 6 sessions. Is once per month. The first one was in April. The last one will be in December. And the format is that every session is moderated by a duo of an expert physician and a patient advocate who build together the speech, who elaborate together the speech. We had already 2 sessions, one on how to connect patients in Europe to cutaneous lymphoma expert via the ERN. The other was an introduction to cutaneous lymphoma with the 2 prevalent subtypes, mycosis fungoides and Sézary syndrome. Both videos are already available on YouTube channel if you want to have a look at them. And today, finally, we are going to have a lecture on introduction to cutaneous lymphoma, other subtypes, diagnosis and staging with 2 speakers. I'm very proud to introduce, even if they need no presentation. So first, I will introduce Professor Antonio Cozio, who is chairman at the Department of Dermatology, Venerology and Allergology in Kantonsspital St. Gallen in Switzerland. And Professor Cozio is currently member of the board of directors of the International Society for Cutaneous Lymphoma, has served as secretary for the board of the Cutaneous Lymphoma Group of the EORTC, and is a founding and board member of the Swiss Group for Cutaneous Lymphoma. His principal research and clinical interests are immunodermatology and immunotherapy of skin disorder, including cutaneous lymphoma. And Susan Thornton serves as the CEO of the Cutaneous Lymphoma Foundation, a worldwide nonprofit that empower, educates, and support people diagnosed with rare cancer. And she serves also as a board chair for the Lymphoma Coalition and has held a leadership position as a vice chair of the International Alliance of Dermatology Patients Organizations and vice chair of the Coalition of Skin Disease. She also served on the planning committee that hosts the first International Dermatology Patients Organization Conference held in Vancouver, and was a founding member of the IADPO. So, dear audience, please welcome with me these 2 special speakers of today's session. Thank you very much.
Thank you, Mariangela, and it's really an honor and a pleasure to be here. And I'm going to turn the floor over to Professor Cozio to kick us off with the clinical first part of the lecture. So please take it from here.
Thank you very much, Susan. Thank you very much, Mariangela, for this kind introduction. And I have been given the task to discuss with you the so-called other subtypes of cutaneous lymphoma, focusing on diagnosis and staging. You remember roughly a month ago, 4 weeks ago, Maarten Vermeer from Leiden in the Netherlands discussed with you mycosis fungoides and Sézary syndrome. So now I'm taking over the whole rest of the other 10 or so cutaneous lymphoma types, but we will not discuss all the 10 or so lymphoma types or 15, but rather focus on the most important ones. And this is the schedule we have to. I would like to discuss with you. First, I would like to give a short introduction again on lymphoma and an overview. What is lymphoma? What is cutaneous lymphoma? What is Hodgkin? What is non-Hodgkin lymphoma? What is nodal? What is extranodal lymphomas? All those things that you'll encounter when you Google information about your disorders, and that all these things that may also kind of be confusing. And to tell you the truth, many of these expressions are actually also confusing for many doctors who are not specifically involved in the field. So after this introduction, I will then switch to two types of cutaneous T-cell lymphomas of the so-called CD30 positive type, namely lymphomatoid papulosis and this ALCL type of lymphomas. Then we'll have another short break, and then I'll focus on the three types of B-cell lymphomas before we go into the open discussion. So that's the schedule for today. And let me start a very simple. I'm really sorry, I'm not an expert in drawings, but I went through the hassle of trying to depict the most important things. And so let's start with lymphoma, leukemia, lymphocytes, all these expressions that you may encounter on the internet. If you look at a droplet in your blood, most of the cells in red blood cells, and only about 1 per mil, so in 1,000 to 1, are white blood cells. And these white blood cells are the ones that are interesting. So already from this sketch, you will realize that even if you have Sézary syndrome, it still means that 99.9% of your cells are healthy, and only a very minute part of your blood is actually leukemic. But let's focus on these white blood cells, the 1 per mil. So the white blood cells, they can be separated in something called thrombocytes, in something called the myeloid cells, and in a third group, the lymphoid cells. And the myeloid cells are the ones that eventually, if they become cancerous, can turn into so-called myeloid leukemia. And the lymphoid cells, the lymphocytes, they can become either lymphoid leukemia or lymphoma. We will talk about the difference between leukemia and lymphoma. The lymphocytes, again, can be separated in B cells, T cells, and the so-called NK cells. Now, what do these letters mean? They simply mean B cells are derived from bone marrow, hence B, whereas T cells are derived from the thymus, an organ that lies behind the breastbone, an organ which is important only during embryonic period of time, maybe early childhood, but then disappears. So T cells derive from thymus, and NK cells stands for natural killer cells. They take care of infectious diseases if the B cells or T cells cannot get rid of the attacker, then they may be helpful. So lymphoma, oma always means in medicine, obviously cancer, melanoma, basalioma, spinalioma, carcinoma, all means cancer. And the lymphoma is a cancer of lymphocytes in a solid 3D form. So a lymphoma of the liver, in the spleen, in the skin, that is in a solid form. A leukemia may also be a cancer of lymphocytes, but then the leukemia means the cells are in single suspension disseminated in the blood system, and they flow with the blood through your body. So that's a simple differentiation between lymphoma, 3D solid, versus leukemia, in the tumor cells are in the blood. And the cutaneous lymphoma, that simply means that the lymphoma originates in the skin. It does not mean that it has to stay forever in the skin. It may eventually also migrate into the inner organs or into the blood or the lymph nodes, but it stems from the skin, and it's either a CTCL, cutaneous T-cell lymphoma, or a CBCL, cutaneous B-cell lymphoma. So these T and B cells are obviously important cells, and I would like you to understand a little bit more what these cells actually do as a normal job, because that may be helpful also in understanding what goes wrong when people develop a cutaneous lymphoma or lymphoma of any other type. So T and B cells are derived from the common progenitor cells via multiple steps of differentiation. They develop into mature T cells or mature B cells. And the T cells, their function is basically by direct contact to either a cancer cell or an infected virus, infected cells. They may, by direct contact, kill these cells. So T cells are direct contact killers. That's one of their main job. The B cells, on the other side, they have not a direct contact with the cancer cell or bacteria, but they secrete antibodies, and these antibodies may then help tag the cancer cell and help them killing, or they may tag bacteria, and this tagging helps them eliminating bacteria or also cancer cells. So both the B and the T cells are, if you want, they have a kind of a police function in the body. And now if this normal function of police function, of immune function goes havoc, then we may have problems in the lymphoma cases. We may have problems with infection. That's actually the case in advanced stages of cutaneous lymphoma. If the lymphoma takes over the normal function of the B and T cells, this function cannot work properly anymore. We have a dysfunctional immune system, we have a dysfunctional immune defense, and the people with cutaneous lymphoma, mainly cutaneous T-cell lymphoma, suffer from many infections that may actually, in the end, be one of the major causes of death if the immune system breaks down. On the other side, we also know that some of the viruses, if they infect B or T cells, or if they trigger immune response, they may actually sooner or later lead to lymphoma. For instance, EBV virus infection can lead to lymphoma, or in some cases it has been described that also bacteria such as Borrelia can also lead to lymphoma. And the final question I would like to discuss with you in this little bit sketch way is, what is nodal and what is extranodal lymphoma? What is Hodgkin's versus non-Hodgkin's lymphoma? So that's a simple one. Nodal lymphomas arise in the lymph nodes, and the lymph nodes are located in the folds of our bodies, basically strategically situated to defend us against infections. For instance, here in the axilla or in the collar area, but also in the groin area, along in the inner parts of the organ, in the chest or in the abdomen, but also in the knee folds. So basically in all folds, we have lymph nodes. If the lymphoma arise in the lymph nodes, we'll talk about nodal, so-called nodal lymphoma. They may be Hodgkin's lymphoma or non-Hodgkin's lymphoma. The only difference, whether it's a Hodgkin or a non-Hodgkin lymphoma, is only basically if you see Hodgkin's cell, a specific kind of B cell, then we'll talk about a Hodgkin lymphoma. If these cells are absent, if other specific markers are present, then we talk about non-Hodgkin's lymphoma, which are way more abundant than the Hodgkin lymphoma. On the other side, if the lymphoma does not arise in the lymph nodes, but rather in any other organ, and the most prevalent one is the gut organ where extranodal lymphoma arise, then we talk about these so-called extranodal lymphoma. The second most prevalent site for extranodal lymphoma is already the skin. So one of the largest organ in our body is also the second most prevalent location for formation of extranodal lymphoma. And these lymphomas, they are virtually always so-called non-Hodgkin's lymphoma. And all the skin lymphomas are non-Hodgkin's lymphoma. And we can understand the concept of extranodal lymphoma very easily if we understand that B and T cells are so-called police cells. Obviously, the police has to be able to traffic through the entire body. If they settle down in a specific organ and become turn into cancers, they may develop a lymphoma of this specific organ. And virtually any organ can start in that case. The lymphoma and the skin lymphoma, I told you already, are the second most frequent site for lymphoma. And this is this is confusing not only for you, but also for many doctors, actually also for the specialists. It's very confusing because the classification of lymphomas, they keep changing every 2 to 5 years. But I must tell you that at the given time, this is by far the best classification we ever had, specifically for specialists in the field of cutaneous lymphoma. I think the time has never been as good as it is now. If we want to compare, for instance, experiences from a specialist in Holland with experiences in Switzerland or in the US, we have to rely on a common language, on a common classification, on a joint classification. And this is the case now with this classification. It is confusing, but it is still the best world we ever had for cutaneous lymphoma. And the problem is that if, and this is obviously also important for you as patients, you have to make sure that your doctor knows what he's talking about if you suffer from any forms of lymphomas. I tend to believe that I understand a few things about cutaneous lymphoma. I'm not always sure, but I would never, ever allow myself to discuss proper treatment of a lymphoma of the gut or any other organ, because these things are so specific, individual, that you have to be specialist on the field to discuss procedure with the patient. And we know that I've told you that B and T cells via various steps, they develop into B and T cells, and each and every of these steps can go wrong. And therefore, we believe that there are so many kinds of B and T cell lymphomas as we encounter, obviously, given this list here. So this is the list of cutaneous T cell lymphomas we know or we accept in the classification, and the cutaneous B cell lymphoma, the list we accept in the current classification. This is the frequency of the individual lymphomas, and this is the 5-year disease-specific survival. So it tells us 88% of patients with MF survived after 5 years, and 12% died from the disease, not by a traffic accident or by any other unhappy event. You have been discussing with Martin Vermeer, with Professor Vermeer, roughly the 50% of cases of mycosis fungoides, plus the variants of MF and Sézary syndrome. So today's task will be to discuss with you these two entities, the CD30 positive lymphoproliferative disorders that make up roughly 20% of the disease of all the cutaneous lymphoma. And you see that their survival is obviously, the 5-year survival is obviously very good with 95 to 99%. Virtually nobody with that diagnosis dies from the disease. That is a positive message. And also I would like to cover another 25% of cutaneous lymphomas from the cutaneous B-cell lymphoma field. And you see that 2 of the 3 entities also have an excellent survival, 5-year survival, whereas the one entity, the diffuse large B-cell lymphoma, has a worse outcome. Approximately half of the patients die within 5 years. So taken together with Professor Vermeer's discussion and my input, you will encounter more than 93% or so of cutaneous lymphoma. But there are many, many more and many, many individual ones, but you see they are actually very rare, with the exception of this provisional entity that has not been yet fully included into the cutaneous lymphoma classification. So this is the field we'll be discussing, cutaneous T-cell lymphomas in the first line, and then cutaneous B-cell lymphomas. And even though all these pictures look very different from each other, if you're familiar with the field of cutaneous lymphoma, then it's fairly easy to make a diagnosis just by clinically looking at it. And that has been the major impact of this current classification, because it is a heavily clinical classification. It focuses on the clinics, because the clinic is one of the leading markers for actually making a diagnosis. And that's why I state here that the clinical appearance is often suggestive for the diagnosis, and it is very important to allow a proper diagnosis and then making the exact the right judgments for a treatment and prevent over treatment, because histologically a cutaneous lymphoma, for instance of the MF type, may look very much similar to another type or to other types of lymphomas which may ask for a more intense treatment. And so you have to know the clinical setting of the patients in order to define the proper treatment for the patient. So this is my first set of information I wanted to give you. And I want to interrupt here my talk and ask you whether you have any questions regarding my 5 or 10 slides so far.
Thank you, Professor Cosio. I think that was a wonderful overview, and your artwork was brilliant, much better than what I could have done. But thank you for that, because I think one of the things that's so important in this rare group of diseases is putting it into context and where they fall within the bigger picture of all of the different lymphomas and leukemias. And, you know, you talked a little bit about the classifications of the different variants of cutaneous lymphomas. And I think from a patient perspective, maybe you could talk a little bit about why understanding and knowing your specific classification of disease, you know, what's the name, what's the stage, what does that really help inform from the clinical perspective, right? The treatment methodologies. And you just mentioned the fact that it's so important not for these diseases not to be over-treated. So maybe you can comment a little bit about why it's so important for individuals to really know what their subtype is and stage, and why that's important from a clinical perspective.
Thank you very much for this very important question. Maybe I have to talk a little bit about the situation that we encountered maybe before, or let's say in the 90s or in the 80s of the last century, where basically people were using, or doctors were using different classifications and different names for the same lymphomas, but they didn't know that they were talking about the same lymphomas because they were using different names based on different classifications. So people in Switzerland, of let's say my predecessor here in St. Gallen, he was maybe encountering 2 Sézary patients in 10 years. And that just does not give you the basis to actually learn from also the mistakes we're making, but also learning from other inputs, because he didn't even know that somebody else was having Sézary patients, because they were talking about this is a form of leukemic lymphoma and not Sézary. So there were 2 different names, but the same entities. Nobody knew whether you could compare the results in the US with the results in Switzerland. And now, given the same and united classification, we can actually start collecting our own experiences and compare them with experiences in other countries. And for the first time now in the EURTC, in a joint venture with the American colleagues, international colleagues all over the world, we have now a collection of more than 1,000 patients with mycosis fungoides from all different stages. And now we learn a lot whether our treatments actually do work for the patients, or they do more harm than good. And this is really something we only learn with big numbers. And finally, based on this classification, we have big numbers. That's the major advantage of the classification, I think.
Thank you. I think that's so important also to put into context that bringing together the international clinical community to share the experiences of the patients is relatively new. You know, you speak about the 1990s. So when you put that in context with some of the other lymphomas that have been perhaps a little easy, maybe not easier, but, you know, more collaborative efforts in our world in the cutaneous lymphomas, it's way more recent. So, but we're learning fast. And I think technology is helping to pull all of those things together, and the collaboration amongst the clinical community globally is really impressive. I think, at least from my perspective and from a patient perspective, the fact that the community internationally on the clinical and research side collaborates so beautifully together on our behalf to find new things and understand the disease is really gives us a lot of hope for the future, not only just today, but what's coming down the pike.
Absolutely. I remember 20 years ago in the international meetings, we have been a group of 20, 25 people meeting in wherever, all over the world. Nowadays, it's our meetings there are people up to 400 people now joining the meetings, and especially many young researchers are moving into the field. So that's actually a hopeful perspective for all the patients actually in the field.
Totally agree. Okay. Next round.
Good.
CD30 positive lymphoproliferative disorders. That's a big mouthful. I'll let you take it from here.
Can you see my screen?
Yes.
Good. So we'll have a short discussion on these 2 forms, the so-called primary cutaneous CD30 positive LPD, stands for lymphoproliferative disorders. There are 2 groups of these lymphomas, and we'll discuss both of them shortly. Keep in mind that actually they make up roughly 1/5 of all lymphomas. So they are fairly prevalent. that still means that there are only roughly 1 in 100,000 per year. So a given population of Switzerland with 8 million people will see about 50 to 80 of these patients every year. So there are not many patients in Switzerland, and for other countries the numbers are roughly the same. The lymphomatoid papulosis, or we'll abbreviate it shortly to LYP, starts often with small papules that look very, very innocuous. They are not itchy, they just grow slowly over a period of 4 to 6 weeks. And interestingly, they start waning spontaneously and actually regress spontaneously after 6 to 8 weeks. And often after 3 months, everything is gone. So they may, however, become more numerous. If you only have one lesion, then many patients with LYP, they may not even go to the doctor because they disappear again. They may come back eventually at another site, but they disappear again. But if obviously, if that's the case, in a group of lesions popping up, then that gets a little bit disturbing, and patients actually want to have a diagnosis. But that's a typical aspect. They do not become larger than a centimeter, roughly. If they become significantly larger than a centimeter, we have to think of other forms of lymphomas. They may actually become more numerous and more prevalent and become very disturbing. They do not itch, they are not painful, but obviously aesthetically they are very disturbing, and they may also be frightening because you just don't know what's going on in the body. Interestingly, even though the histology looks very aggressive, and if a histopathologist looks at it that does not have an idea of the location of the tumor, then he will write back a report stating that this is a highly aggressive non-Hodgkin lymphoma. And if you're not in the hands of a dermatologist who knows the disease, you may get an overtreatment with heavy, eventually polychemotherapy. But that would be absolutely exaggerated in this situation, because lymphomatoid papulosis is a waxing and waning disorder, and invariably is self-limited and virtually never leads to death. It's a chronic disease, that is unfortunately true, but the people do not die from LYP. However, we have to be careful in these patients, because even though the long-term prognosis is excellent, people with LYP have a significantly increased risk for other lymphomas, such as mycosis fungoides, such as Hodgkin's lymphoma, or such as anaplastic large cell lymphoma, the one we'll be discussing in a couple of minutes. The lesions may disappear over time, but they leave hyper or hypopigmented lesions that may be disturbing for the patient. But once again, the disease is benign, and it has been discussed many times. Basically, on each Congress, we'll discuss whether LYP should be part of the cutaneous lymphoma classification or not, given the fact that it does not kill. I am a strong supporter of LYP, keeping it in the cutaneous lymphoma classification, because we can learn a lot from histology and from these cells if we only study hard enough. Again, this is how LYP looks, a little bit scaly on the surface. It should not be larger than a centimeter, and that is actually a treatment, an accepted treatment for this LYP. We do not talk too much about treatment. That will be in further meetings you will have with other specialists, but surgery is an accepted treatment. Obviously, if you have dozens of these lesions, surgery is not the way to go. We have to find another way. I was given the task to talk about the diagnostic steps for LYP and ALCL. That is true basically for any cutaneous lymphoma we'll be discussing, so I want to take a couple of minutes for these diagnostic steps. The first one is, as always, our organ, the skin, our organ of interest is accessible, so a biopsy is easily done and not too bad for the patients also, local anesthesia, and the histology helps us actually separating LYP from inflammatory diseases, from other neoplasms, or from infections or whatever. So skin biopsy is a very important first step in the diagnostics. The second diagnostic step is we want to make sure, we want to confirm, either confirm or exclude that the disease has spread to the inner body, to organs or lymph nodes. This is what we expect if we do a PET scan or a CT scan, no involvement of the inner organs or lymph nodes. If, however, we encounter positive signals, be it in organs or in lymph nodes, then we have to make sure that these, we have to really be sure that these signals are actually neoplastic, so cancer signals, and derived from the lymphoma we investigate. So in these situations, we have to do a lymph node excision or an organ biopsy and do analysis of the organ or the lymph nodes. But this is rarely, never necessary in LYP, never necessary, extremely rarely necessary. The next step that is important, obviously, is a blood test. Unfortunately, there is no specific blood test that it actually pinpoints down the type of cutaneous lymphoma or is specific for follow-up of cutaneous lymphoma. Nevertheless, it's always important for the doctors to understand how are your blood cells doing, how is your kidney and liver doing, because some treatments may be damaging kidney and liver, and if these are already damaged, then these treatments obviously are a no-go. And LDH is always performed a measurement of lactate dehydrogenase. This is a helpful tool. If this one is increased, that tells us we have to be careful about some neoplastic disorders. But that's a very unspecific test. It also may be positive in melanoma and many other cancers. And finally, bone marrow puncture is a possibility if we look for cutaneous lymphoma in the bone marrow, very rarely necessary and never necessary in LYP, never necessary in LYP. So for LYP, what we need is skin and imaging. That's all we need, and the blood. That's all we need. We do not need further analysis. Now that has been LYP. Now let's say the larger brother of, or the older brother of LYP is ALCL, anaplastic large cell lymphoma, and the PC stands for primary cutaneous. So first appearance of the tumor happens in the skin, primary cutaneous ALCL. And they look very similar to the LYP we have been looking at before, but they do not stop at the size of 1 centimeter and decrease over time, but they just keep growing. And when they grow, they can become actually really, really large, much larger than also these lesions. They may grow up to several centimeters. If we look at, if we see these situations, obviously we have to take a skin biopsy for diagnostics. And we know also in this situation, the histology looks very scary, looks like very aggressive lymphoma. But if we know that the lesion occurs primarily in the skin and first in the skin, no involvement of inner organs, then we can confirm a very good prognosis to the patients, and we can save him from an overtreatment with polychemotherapy. But nevertheless, we have to check for dissemination, and we do that usually with a PET scan, and we see that we only have a signal here in the right, in the left axilla, which corresponds to the clinical lesion we also saw in the patient. The heart always shows a signal in the PET scan, that's normal. The kidneys always show a signal in the PET scan, that's normal. And the kidney, the urine flows into the vesica here, and that's always a normal signal. Also, the brain heavily relies on sugar metabolism and always has a positive signal. So these are all normal signals, but this one is a pathologic signal, telling us we only have an involvement of the skin and no inner involvement. That's a typical patient with anaplastic large cell lymphoma. They are rather young patients, 30 to 50 years old, and the signal and the histology invariably basically shows CD30 positivity. We will talk about this marker in a minute, because that's a very important marker. Staging was negative, so we did the PET scan, we checked in the blood, everything was fine. We did not have to do bone marrow puncture. This is not indicated in these tumors. And we decided, because it was a localized disorder, we decided to perform a surgery, excise the tumor, and follow up with a local radiotherapy. The patient has been without tumor in full remission for more than 10 years now. CD30 is a very useful marker for LYP and ALCL, and you may have asked, what is a marker and what is CD30? So I try to depict that here also. This is supposed to be a tumor cell, and the tumor cell is delineated by a cell membrane. That's basically the outer border of the tumor cell, and in the inside there are many important things for the cells to grow, and one important thing is the cell nucleus, where all the genetic information of the cancer cell is stored. And on the surface of the base of the cell membrane, there are different antigens or so-called CDs. That's a cluster of differentiation. That's the abbreviation. So all these different surface markers are actually markers that the individual sets of markers defines basically the cell type. And based on the analysis of these surface markers, we can actually define whether we are dealing with a lymphoma cell, whether we are dealing with a normal brain cell, whether we are dealing with another skin tumor cell. So these surface markers tell us a whole lot of things of the type of cells we're dealing with. And CD30 is an extremely useful marker for these diseases, because it allows us to tell now we are dealing with LYP or ALCL, or in rare occasions with a few other cancers that are not the focus of today's discussion. So the important question, not only in a diagnostic way, but also in a therapeutic way, is to understand, is there a marker that is unique for the cancer? If we have a unique marker for a cancer, then we can actually, by finding this marker on a cell, we can positively confirm this is this type of cancer. But then if we know how the surface looks like, we may also use this marker to attack this specific cell. If we know that only the cancers express CD30, we may actually attack all cells that contain CD30 and then eliminate only the cancer cells without harming the rest of the body. So specific markers of cancers are the hallmark of of medical research, of nowadays research. And CD30 is one of these extremely useful markers that helps us finding the tumor and also treat the tumor. And treatment works in a way that we are using antibodies that are created in a way that they specifically recognize the CD30 on the surface. Only the CD30. They would not bind on CD29 or CD31, whatever. They only bind to CD30. If there is no CD30 on the surface, the cell will not be attacked. However, if there is CD30 on the surface, the antibody binds to it, will be internalized in the cancer cell, and the clever trick of this antibody is that they are not only antibodies, but the red dots they are actually carrying with them a toxin. They are toxic medication, and this medication helps killing the cells then. But the medication only will be activated once it is transported into the cell. So if the antibody does not bind to the cell, it will not be transported into the cell, and it will not kill the cell. It only kills so-called CD30 positive cells. And so this is the extremely clever approach of antibody treatment, and we all are desperately looking for specific markers for cancers in order to have an possibility to attack these cancers with an antibody carrying some toxins specifically to the cancers. And this treatment with the brentuximab helps us in the treatment of all CD30 positive cancers, which are mainly LYP and ALCL, but also some forms of mycosis fungoides may have CD30. So at least 3 types of cutaneous lymphoma can be treated with this antibody. And we see that on the y-axis, we have the so-called progression-free survival. That means how long does it take until the disease comes back? So if the progression-free survival, so 100% is at the beginning is obviously after a treatment, there is no, it takes a while until the first patients lose their answers, and after 3.5 months, if we are using the standard treatment, methotrexate or bexarotene, it takes only about 3.5 months, and 50% of all the patients have lost their response and have actually, again, a progression of the disease. Whereas if we're using brentuximab, it does not cure the patients yet. It does not cure our patients, but it prolongs the remission or the progression-free survival, and it prolongs the remission by a factor of 5, up to 16.8 months. That's a long time for some patients, and it gives the doctors and the patients time to discuss further therapeutic steps, whatever they are, but we gain time, and this is really important. So brentuximab is a very important drug nowadays, these antibodies, and we hope that we'll find other antibodies directed against other antigens and markers on the cell surface. So this is the second part of my discussion concerning the LYP and ALCL. Let me know if you have questions so far.
That was very, very good, Antonio. Thank you. And I think, of course, if anybody has any questions, please feel free to put it in the chat. But I think one of the important pieces to this particular group of cutaneous lymphomas is, and one of the things that you raised, is the importance of getting the right diagnosis, which means getting to the right expert in the field, which sometimes can be challenging depending upon where individuals are living if they're not close to an expert center. I think that's one of the exciting things that's happening now with the EuroBloodNet networks and connecting the different clinicians who specialize so that other physicians who may not be experts in the field know where to go and to get the right kind of diagnostics. And I guess my question is a little bit around when, especially if someone has LYP, right? You mentioned that it waxes and wanes and sometimes you don't really need treatment, but when do you make that decision as a patient working with your physician? When do you decide, okay, now we should treat, or when we can just do more of a watch and wait? How do you make those kinds of decisions?
This is a very important question also. Actually, as you said, watch and wait is a valuable strategy with these patients, especially in the patients with LYP with very, very few numbers of lesions. So everything that goes up to 3 to 5 lesions, 3 lesions per month, I tend to try to convince the patient to do watchful waiting, but this heavily depends also on the patient. Is he or she somebody who wants to be on the absolute safe side, or maybe a frightened personality, or there are just different personalities, types of personalities. It's always important to tell them that probably by treating the patients with LYP, we do probably not prolong survival. We don't know, but we probably do not prolong survival. Even if they let the disease flow, probably they will live about the same length, but we don't know. It's always the point, well, we don't want to have too many tumor cells, because the more tumor cells you have in a body, the more of these cells may actually mutate and become more active. So that would be a reason to actually treat the patients, but we'll make that a very individual decision actually with the patient.
Great, thank you. And I know I want to be able to get to your cutaneous B cell pieces as well. So I'm going to flip it back over to you unless there are any questions from our audience on this. All right, back over to you. You're on mute, Antonio.
Okay, now you hear me? Good. Can you hear me? Yes. Yeah. Okay. So we are talking about these 25% of cutaneous lymphoma with the impossible names: marginal zone lymphoma of the skin, follicle center lymphoma of the skin, or even worse, diffuse large B-cell lymphoma of the skin. PC always means primary cutaneous, so they originate in the skin. Eventually they may disseminate in different body areas, but they originate in the skin. Very rare tumors again, but that's what it is. The names derived from special histologic locations in lymph nodes and in lymphoid organs. And that's just what medicine is. Sometimes difficult names to remember, but that's what it is. So I tend to abbreviate them by PCMZL and PCFCL, but that refers to these names. So clinically, actually, they look very much the same. It's hard to differentiate just by clinically looking at cutaneous B-cell lymphomas. And that is very much in contrast to, you remember the clinical pictures I showed you from the T cells. In the CTCL, just by looking at the patient, we can actually already have a fairly good idea of what kind of cutaneous T-cell lymphoma we are dealing with. With the B-cell lymphomas, it doesn't work because they all look virtually a little bit dome-shaped, roundish, reddish, non-scaly lesions, sometimes on the face, sometimes on the leg, or even on the back or the upper arm, but they all look the same. So we have to have histology in order to separate the B-cell lymphomas from each other. So similar clinical appearance despite significant differences in prognosis. So just by looking at it, we cannot tell that we cannot just simply be content with the statement that we probably deal with the B-cell lymphomas, but we have to find the different subtypes because they have differences in prognosis. And we know from experience, again, from collecting hundreds of patients and comparing them among nations, we know nowadays that the marginal zone lymphoma is a disease of rather young people, on average roughly 40 years old. The lesions occur on the shoulders, breast area, and the upper arm. Whereas the follicle central lymphoma are middle-aged people. I tend to state that this is actually still very young, but let's call it now middle-aged. Follicle central lymphomas occur mainly on the head, on the frontal area, head, but also in the shoulder area. Whereas the diffuse large B-cell lymphoma most often occur on the lower legs and virtually invariably in older people, around 80 years on average. So age and location helps us a little bit separating these types, but we have to do the histology. Again, the diagnostic steps I have discussed before. We have to do skin biopsy, we have to do it. That helps us separating the entities from each other. We have to do check for dissemination into the body. That's usually with a PET scan. If we see a positive signal, we have to do lymph node excision or organ biopsies. That may actually occur in the more aggressive forms of B-cell lymphomas, the so-called DLBCL. We also have to do blood tests. And beside these factors, we check for immunoglobulins, because these immunoglobulins are the products of some of these lymphomas, mainly the marginal zone lymphoma. And finally, in the B-cell lymphomas, especially for the DLBCL, we need to have bone marrow analysis. We need to find out whether the tumor has invaded the bone marrow. So mainly for DLBCL, but also some forms of follicle central lymphoma, we have to find out whether the bone marrow is involved. This is the diagnostic steps in these B-cell lymphomas. And it's important to separate them because we know that over a time frame of 10 years, this is month, so over 120 months, we know that the marginal zone patients, they basically survive. They do not die from the lymphoma. This lymphoma basically never kills the patient. Over 10 years, people who died did not die from the lymphoma, but from other causes. We also know that the follicle central lymphoma is maybe a little bit more dangerous than marginal zone lymphoma, but not dangerous in terms of acute endangering the life of the patient. Whereas the diffuse large B-cell lymphoma, that is actually a dangerous lymphoma because 50% of the patient died after 3 years. So there's no time to lose for treatment. We have to make sure that these patients are properly treated. We have to make sure that these patients here can be identified and treated with chemotherapy, whereas these patients here should also be identified, but they should be saved from chemotherapy. It would be a medical mistake to treat patients with these forms of lymphomas with chemotherapy. So you have to be in the hands of a doctor who knows what he or she is dealing with. That's actually the very important question. Is this a shark? Is it an aggressive B-cell lymphoma? Or is it a dolphin? Is it a non-aggressive lymphoma? I would not be a specialist enough to actually decide whether this is a shark or a dolphin. But apparently you can actually separate the dolphin and the shark given by their forms of the fin. If it's triangle, it's more shark-like. It has this roundish aspect. It's more dolphin-like. I would not go too close to that kind of animal to find out whether it's a shark or a dolphin. But the same is basically the problem we're facing when we look at the B-cell lymphoma. The question is it a dangerous DLBCL or is it a not dangerous follicular center lymphoma or marginal zone lymphoma? And we can do that with different markers we're using. The markers on the cell surface I was discussing with you a couple of minutes ago. There are some markers also for B-cell lymphomas. If some of them are positive or all of them are positive, then we are dealing with the shark among the B-cell lymphomas. If the marker setting shows like this, then we are probably dealing with the good guy with the dolphin in the terms of B-cell lymphoma. This just tells you one more time how important it is to have the specific markers for these lymphomas. So very shortly, just in one nutshell, the treatments for the discussed T-cell lymphoma forms. I was discussing with you the LYP and ALCL. I have told you that survival rate is very good with 95 to 99%. That's why we are limiting usually the treatment to so-called skin-directed treatment. UV treatment, topical steroids, maybe surgery or radiotherapy. Maybe in very active cases, some systemic treatments may be necessary. Other specialists will talk about those factors. Clinical follow-up is according to activity, very individually, has to be defined very individually. And we have to do no follow-up imaging if there are no skin symptoms and no so-called B symptoms. Symptoms of indicating that some lymphoma may grow in the internal, in the inner organs of the body. For the B-cell lymphomas, I was discussing with you the marginal zone lymphoma and the follicle center lymphoma. We also know that their survival rate is excellent, 95 to 99% again. So only skin-directed therapy, wait and watch is an option, surgery, steroid is an option, or radiotherapy. Clinical follow-up is again according to activity, and no further analysis once the diagnosis is established and if there are no B symptoms around. The things change totally and dramatically if you're dealing with the shark among the B-cell lymphomas, the so-called diffuse large B-cell lymphoma. That has to be defined histologically, but we always are suspicious if we see lymphoma on the leg in an elderly patient. That is always suspicious for diffuse large B-cell lymphoma. These patients, we have to find out these patients and specifically treat these patients with chemoimmunotherapy in order to help them survive because half of the patient, if not treated properly, die within 3 years. And that's also important then to include these patients into current clinical trials. So that's in a nutshell the treatment for these 5 different forms of cutaneous lymphomas. With that, I come to the end. This is my hometown, St. Gallen in Switzerland. This is my office here. It's actually, I wish it was my office, but it's a library of the monastery here. It's a world famous library. And this has been the meeting, the cutaneous lymphoma meeting I had the honor to organize 3 years ago, where I also met Susan Thornton. And with that, I'd like to thank you for your attention and with that view of my clinic here in St. Gallen. Very nice place if you have the time to visit. Thank you.
Thank you, Antonio. That was really well done. And there's so much you were able to condense into all of those slides in your discussion. I really appreciate that. And St. Gallen is such a beautiful place. I feel so lucky to have actually had the chance to visit and to be there. You'll have to host another meeting soon. So this is probably a good segue. I promised that I would share a little bit about my journey, and I think it speaks to the importance of getting to the right clinician who understands this disease and making sure that you are followed over the course of time. And so I thought, I think, Antonio, you have to unshare so I can just share, and I'll spend just a few minutes to talk a little bit about my experience over the last, let's see, multiple participants. Let's see if we can do that. There we go. I think this is me. Oh, not me. Let's see. Technology is always lovely. Yeah, okay. I'm going to just jump right into my experience with cutaneous lymphomas. And as you can see on this slide, and obviously the hairstyles have changed over time in the last 30 years, and I've aged a little bit over that time period. But I was diagnosed in 1991 with early stage mycosis fungoides, stage 1A. And similarly to so many people with this disease, it took quite a while for me to get the right diagnosis and to get to the right expert in the field. I probably visited with 5 or 6 different dermatologists, and none, interestingly, ever did a biopsy. So I was very fortunate to find a dermatologist who had a suspicion and immediately referred me to, at that time, in 1991, one of the leading experts in the world in cutaneous lymphoma. I did not know that at the time. I thought I just had some benign itchy rash, and I would get another cream and off I would go. Unfortunately, that was not the case when I got the official diagnosis of mycosis fungoides stage 1A. And as I think we've learned along the way in these webinars, generally speaking, most individuals with mycosis fungoides early stage, their disease does not progress. It's a chronic disease that is managed over the course of time. But I was in that very small window of patients and individuals whose disease did progress. Although it wasn't an immediate thing, it progressed over about a 6-year window. And to what Antonio was saying, back in the 90s, there was not as much knowledge of these diseases. There were very few treatments for the disease. And I relatively quickly, in the first few years, ran through the available treatments, which was the UVA, PUVA treatment, and then some topical nitrogen mustard, which was in a very different formulation than what it is today. And by 1998, my disease had progressed to what we call tumor stage mycosis fungoides. Although, again, we weren't doing a lot of the studies and the additional biopsies. We didn't have back in that time all of the kind of diagnostic tools that we have today that would point to some of these different markers and things that we know now. Again, I was so very fortunate to be treated by one of the world's experts. And I had, people don't believe me when I tell them, and I don't have any pictures. Back then you didn't have an iPhone. It wasn't easy to take photographs, but and I really didn't want anybody to take pictures of me, to be very honest. But I had tumors pretty much all in my scalp and over my eye. I had crusty red rash, horrible on my face, and all pretty much in every part of my body. Very itchy, extremely uncomfortable. It was pretty horrific. And for anyone who's listening that has more challenging or aggressive disease, I know you understand what this is like and having to live with this. I was in the spring of '98, my only option available at that time was a stem cell transplant, which was very risky. It's still very risky today, but we have a lot more options in our armamentarium for treatments than were available for me. And I, again, was very fortunate to be treated by an expert in the field who collaborated with the radiation oncologist. And in order to get my disease under control, we did targeted electron beam radiation to all the different tumor areas on my body. And yes, that's me laying on the table having radiation to my face, which was not a fun thing, I can say. But I was very, very lucky that the disease was only in my skin. So our capacity to treat it just in the skin resolved my tumors. And we followed up with interferon at the time, which I think was really helpful. I came out of that experience in 1998. I threw myself a huge 40th birthday party and celebration. You can see the picture there with my mom and dad and my beautiful wig, because they radiated my head and they weren't sure if I was going to have any hair, but it did come back, as you can see, which I'm very grateful for. A little bit curlier and a little grayer. I kind of take after my dad in that arena. But, you know, I felt so fortunate that I was able to come through this experience and decided that I wanted to give back, and began doing a lot of volunteer work for different patient organizations at that time. And then in 2008, I actually continued to do various therapies over the course of the next 10 to 12 years with targeted electron beam radiation and interferon and some topicals. We mixed and matched based on how my disease was showing up. And again, I think this points to the critical nature of being treated and working collaboratively with your physician over the course of time. And as your disease, as an individual, is going to show up differently, even if you have the same exact diagnosis as someone else in your body, it's going to look a little different. So it's so critical to have that relationship with your treating physicians, and to be able to discuss the right treatment options, especially now that we have way more therapies that are available and more things that are coming through the clinical trial pipeline, which is extremely exciting. And my beloved physician, who was my treating doctor for 15 years, decided to retire, and I had to seek a new physician. And I happened to land with Dr. Stuart Lesson, who helped to establish the Cutaneous Lymphoma Foundation with Judy Jones, actually back in 1998, which I didn't know them or meet them until 2008. And that opened the door for me to become very active in the patient organization side of my disease and interact with the physicians at a global level, to participate, listen to the science, and then to really be able to bring all of that information back to the patient community. And to be here today, to really be able to bring this very important information to patients, no matter where they live, through technology, is fabulous. And while we have a lot of work still to do in bringing the patient community together and making sure that each individual is able to get to the expert in the field that's closest to them in their geography, I think we've made some amazing strides. And the fact that we are here today sharing this through the support of EuroBloodNet and the connection that they are doing with the clinical community, and being part of Eurordis and our friends at the Lymphoma Coalition and the French Lymphoma Group, I think really speaks to how critical and how exciting it is for patients today versus where I was in 1991. So, and I know we're a little bit over time. There's so much more that I could talk about, but just so that we don't keep you any longer, I will open it to any questions, but it's really been an honor and a pleasure to share a little bit of my journey and how exciting it is now that we have this great chance to connect people around the globe, the clinical community and the patient community, for the greater good of all of us. Because the more that we can come together and the more that we can share both the clinical side and the research, but the patient experience, the better we will all be in actually being able to live with this disease and maybe even someday cure it, or at the very best, be able to have some really good treatments where we can alleviate the disease for the most part. So anyway, I will finish up with that. And Mary Angela, I'll flip it over to you to see if there's any other last things, or to Antonio, if there's anything else that he would like to share at this point.
Well, I'll let first Professor Cote to answer, of course.
Thank you very much, Susan, for sharing with us your personal experiences. I think this is exactly where we are at now in the field. Like you had, why is it? Luckily, you survived, but why is it that somehow your cancer or your body was able, with the help of medical aid, to destroy the cancer or to control it? And this is specific, actually, the question also we are asking nowadays in a huge worldwide joint venture, let's say the ProClippi joint venture, where we collect hundreds and hundreds of patient experiences, epidemiological data, personal data, plus also with the help of Martin Vermeer, then kind of federated biobanks where we have tumor samples. And so we can compare the outcome of patients with their individual treatments, with their epidemiological backgrounds, but also with, hopefully, with the genetic information from their tumors. And we really hope that with that activity, we can actually push the field forward and understand and help selecting the right treatments for the right patients. I'm very happy that it worked out so well for you.
I'm very fortunate and very lucky. And I feel very guilty that we didn't capture some of my tissue. I keep telling people that I have to go volunteer to give some of my tissue so you can do some analysis and see maybe why things work so well for me and what was that experience can help others. So, it's on my list one of these days.
Okay, so I think we should close the session, and it's always a pity when you have such great discussion and debate. So I'm wordless, so I don't know how to express my gratitude to the speakers for today's session. So thank you very much for have shared all your expertise.